Assalamu alaikum viewers. Today we are discussing a case here where we were doing a left-sided simple nephrectomy for a non-functioning kidney. So we have already mobilized the colon, identified the ureter and the gonadal vein, and we have reached the renal vein. Here you can see we were doing dissection here, and suddenly the bleeding started. So this video is all about this bleeding, how to stop it, how to know from where it is coming. So there is a certain gush of blood. I was trying to coagulate the area with the ligashore, but I couldn't. So I realized that I need to quickly clean the area, put in the diathermy lead on my bipolar forceps, and try to coagulate and suck at the same time. So initially what happened, now here I'm using the saline to dilute the blood and do the suction, and this saline will also help to the bipolar forceps for coagulation, as we all know the mechanism of action. So here I'm using constant suction, but it's difficult. So after using the bipolar forceps, initially the bleeding stopped, and I washed the area again, but my sixth sense was telling me that it's not all right and we should not proceed with the further dissection unless and until we deal with it. So we keep on coagulating. So there are a few steps to control the bleeding when it starts. Number one, you can just compress the area between the forceps. You can use a suction device. You can put in another extra port for the suction. You can coagulate the area. But if it is not responding to the coagulation and all those steps, then of course one has to compress the area. And if it doesn't stop with that, then we have to use a gauze or something to control the bleeding. But if it doesn't control with the gauze compression as well, then of course we'll have to use sutures. And if it doesn't control with the sutures, then maybe you'll have to convert the procedure to open. So here you can see that we are trying all the maneuvers. I'm trying to coagulate, and I'm trying to look for the bleeder. I'm also worried about as you can see, we are right on the hilum. There may be some arterial branches coming out of the aorta, or there may be surface of the aorta which is bleeding. This bleed may be coming of the adrenal vein. However, we are desperately trying to control it. But the more we try to control it, the more it gets worse. And the most worrying thing for me at this stage was that initially the color of the blood was a little darkish blue, darkish red. But with the process going on, and we keeping on coagulating and trying to coagulate that vessel, the color of the blood is becoming more and more red, which gives me an idea that there might be some arterial bleeding involved. So we go to the next step, which is the compression by gauze. So we put in the gauze, the dry gauze, and then we suck it, we wash it with normal saline, we suck it again. So we decided to keep it compressed for good 5 minutes, and we stopped doing everything else. We just kept the gauze there and kept on compressing it. After 5 minutes, you can see here that we have stopped compressing it, and there is no bleeding. So I told my fellows and my surgeon fellows, my assistants, my cameraman, that we should keep on progressing slowly and gradually. Zero the camera, put another port for the assistant, and slowly and gradually progress towards the hilum and see if we can find the artery so that we are able to clip it. And if we clip the artery, I'll be more bold, I'll be more courageous. So here you see there is a small vessel which was coagulated by the ligashore forceps. However, it kept on pounding, so I didn't want to open another battlefield for me, so I just clipped it also. Moving forward, you can see another small vein draining into the gerotas or the kidney lower pole from the gonadal vein. So we dissect that as well, we clip it, and then we cut that vein between the clips. But here again, I'm very doubtful about the edge of the vein beyond the clip, because it may slip at any times. So I told my cameraman and my assistants that please remind me in the end of the procedure so that I can clip this gonadal vein. At this point, I don't want to put another clip on the gonadal vein towards the renal vein, as this may hamper my clipping of the main vein. So after completion of 10 minutes, we just removed the gauze and saw that the bleeding has stopped. So now I'm more desperate to try to find the artery before it starts bleeding again. And luckily, here we can see that, as I always mention in my previous videos as well, that this is the most common location of the artery. Here is a lymph node, maybe inflammatory, because she had a pyonephrosis previously, which was treated by percutaneous nephrostomy. And we are lucky enough that we find the artery here. So this whitish wall is peeping through all that tissue. That is a sign of hope for me, and it gives me courage to further dissect this tissue from the artery. And I'm trying to dissect the tissue around the artery, in the vicinity of the artery, so that the clip can easily be applied. So we now know where the artery is. With a thumping heart and a pain in the stomach because of the stress, we keep on dissecting that artery, which is now showing more. Here you can see it's a nice big artery here. It's a big one for a non-functioning kidney. So the art is to keep calm, don't get stressed, try to hold the bleeding vessel with a forceps, of course a non-crushing one. And in the meanwhile, try to wash the area, do the suction, and think what are you going to do. At the same time, while I was compressing on the vessel, I asked about my open trolley. Is it ready or not? Always remember, always and always, the open trolley or the instrument required for opening up the patient, they should not be in another room. That trolley should be standing ready by your side, so that you are ready to open up the case within minutes. And while deciding to open the case, one of the surgeons must keep on holding the bleeding vessel, and the cameraman must also keep on watching the bleeding area. In panic, what happens that the cameraman, the assistants, and the main surgeon, they all rush to open the patient and they forget about what is happening inside. So always keep two people, one for holding the bleeding vessel and the other one the cameraman. So we use the right angle again with a bit of a fear in our hearts that mobilizing and dissecting the vein may cause the bleed to happen again. But we were lucky here that no bleeding occurred. So you can see the magic that has been done by the gauze. But one thing must be kept in mind, that one of the assistants, at least one of the assistants, must keep an eye on the gauze, so that after the procedure ends, that gauze is surely removed from the patient, because it kind of mixes up with the tissue, gets the red color, the brown color of the muscle, the red color of the blood and the clots, and the dissected, bleeded, the tissue which has bled. It takes up all those colors, and it's difficult to. This is most probably the retrograde blood. I don't usually use the ligashore or harmonic or any other source of energy near the clip, because it destabilizes the clip. I always use a scissor for such purpose. Here you can see the edge of the vein that I was talking about. So we have removed the kidney, and now we have clipped both sides of the gonadal vein. Thank you very much, and thank you for my team, Dr. Jamal and Dr. Hasib. Thank you.